Thank you very much. I'm very pleased to be here. Thank you to Cahspr for this invitation, as well as the Pharmaceutical Research Consortium. So we have a hybrid model in Quebec. Is this a drift? I'll be addressing 4 dimensions of this plan: the issue of access, equity, and financial sustainability. Then we'll take a look at which reforms might be required. In Quebec, we have a hybrid public-private universal plan. It is universal, so everybody is covered, hybrid either through the public sector or the private sector. In terms of drug access, Quebec really is a model if we compare ourselves to the rest of Canada. In Quebec, only 4.4% of Quebecers say that they did not fill a prescription due to financial reasons, whereas in Ontario it's about 12%, as well as the rest of Canada. In terms of access to drugs, Quebec really has earned a high mark. Despite all of this, things are not perfect. When you look at co-insurance or deductibles, then the financial situation of individuals generally determines the access to drugs. Nonetheless, Quebec is well positioned. The equity of the hybrid plan, and that's a bit more problematic with respect to equity, fairness. When you look at the public plan, the annual premiums are based on the net family income. So we're trying to assure equity in the public plan. When you look at the private plan, this concern for equity disappears. The contribution of a worker to a private plan is compulsory if this plan is available. So the notion of being compulsory is important. Any employer offering benefits to employees must include this drug insurance in Quebec. However, you do need to see that for employees, the premiums for private plans are not based on their income. They're based on the amount of expenditures in the insured group. So it depends on how many drugs are used by the work environment. If you have 25 employees, elderly employees, let's say, who suffer from more chronic diseases, then the premiums will be far higher. And this may not have any relationship to the income earned by the employee. And I've worked with consumer groups as well. I've also worked with the Union of Consumers. Protégez-vous is one of them. We looked at a number of cases. A full-time student in Sherbrooke who's married, 1 child. Everybody's healthy. She works 2 weekends per month as a beneficiary clerk. She earns $514 monthly, but the compulsory monthly premium is $190.38. So this is precarious work. She has some difficulty, and it's very difficult to incite people to pay for premiums that are so high. Here's another case that we looked at. That was with the society, the SARTEC, of radio, television, and cinema creators. These are basically freelancers. They're self-employed. These people were somewhat older. They had full-time precarious work, if you like. And they came together to be able to provide themselves with a certain amount of financial security, but they have to include drug insurance. Then we had cases that made no sense. A family with a net income of $20,000 a year had to pay a total of premiums of $2,500 per year. So in that particular case, the person belonged to the SARTEC, but this was voluntary. She is not a member of the SARTEC, but in that case, she has no other options for ensuring financial security. We looked at another case. It was AIDS patients, and not because of discrimination, but when they were hired, and the next year, once the premiums were reviewed, because these annual premiums are based on the previous year's figures. So a year after having been hired, the increase of all the premiums in the workplace was quite tremendous, and people complained that the person was now part of the labor force. So for 25 employees, the cost of treatment for this person was $12,500 per year, which translated into an increase in premiums of $500 per year per employee. So this is a question of fairness, equity. And we're now moving to the cost issue, which I think is the most important. Quebec spent about $6.97 billion in prescriptions in 2010, and since 1995, the portion of expenditures for drug went from 8% to 20% of all healthcare spending, and drug expenditures represent 25% of this healthcare spending growth in Quebec. Public expenditures represent about half of the expenditures in private, and there are also private costs paid for by the patients. But this is important. Among OECD countries, Canada is the second country after the United States in terms of how many private insurers we have to provide drug insurance. And Quebec, and we're one of the first among the Canadian provinces with that respect. So if we were to look at the cost of prescription drugs, and that was for 2005, it's a little bit older for OECD countries, and that's the retail price, the manufacturing cost, the margin for the wholesaler, as well as prescription cost for the pharmacy, as well as taxes if applicable, so the retail cost for the same units of drugs. So Canada was more expensive than the United States, more specifically for generic drugs, and that's scandalous. And Quebec was the most expensive provinces among the other Canadian provinces. So we're paying more for drugs. A number of things explain this. We accept that the price of drugs is artificially inflated as a cost to pay for R&D. But what worries me is the annual growth. We have a real average growth per capita from 2001-2009. Growth in Canada. You have to know that we control costs as less than any other countries among OECD countries, and Quebec scores the lowest. If you look at countries like France, the UK, Switzerland, Sweden, all of these countries have some kind of universal public drug insurance plan which is able to better control costs than we are. Why is it so expensive, and why is there such strong growth in costs? And the main reason is that private insurance is inefficient. The administrative costs are higher. They're 8% for a private insurer and 2% for the public regime, the RAMQ. And this is something I found fascinating in my research. When you look at the financial structure of private plans, the private insurance companies for drug insurance, whether these be for a specific plan or whether you only charge for the administrative costs or whether it involves some kind of technicality, at the end of the day, the insurance carrier is paid as a percentage of expenditures. So the financial incentive does not consist in lowering costs. In fact, their financial incentive consists in increasing costs as much as possible. So clearly there's competition between the insurance carriers, but we have a monopoly there. We have three main carriers who control the drug insurance business, which is a problem. At the end of the day, when it comes to the economic structure, we still have this financial incentive, which causes them to increase costs. In terms of the private plan, you cannot negotiate better prices. In Quebec, blatant cost is the cost of prescriptions. Prescription costs and pharmacies and margins are far higher in Quebec compared to other provinces. And the prescription costs of private plans are far higher than they are in the public plan. On a public level, there's regulation. It's around $8.65 per prescription. Whereas with a private plan, the same drug, there the prescription cost can be $10, $20, $30, $40. It all depends on the pharmacy that you go to. There is no regulation, except that the insurance carrier has to automatically reimburse the prescription costs, although this might be considered to be excessive. A further problem, which has to do with the current environment in the pharmaceutics business, where we're seeing an increased number of confidentiality agreements, since the public plan also determines the prices, determines how much it costs to manufacture a drug as a result of the current system. On the one hand, private insurers do not do these confidentiality agreements. They cannot obtain additional drops in prices as a result of a confidentiality agreement, but they also prevent the public system from entering into these confidentiality agreements. As a result, we see increased inefficiency publicly, whereas the public plans in all other provinces except for Newfoundland are party to these confidentiality agreements, which make it possible to lower costs. Last point. Private insurance, no discrimination of new drugs, even though these may not present any therapeutic benefit. I think it's 15% of private drug plans that are open. That is, any new drug can be accepted for reimbursement, even though these may not represent any therapeutic benefit. Basically, 80% of new drugs, rather more than 80% of new drugs on the market represent no therapeutic advances compared to what currently exists. So in my report of 2010 on drug insurance, and I had looked at all of Canada, we had a static comparison between how much we're currently paying and how much we would pay if we had a public universal system. So we need to account for the fact that we would have this public, we would look at this public system as of the first dollar spent, that is no deductibles. So there is an increase in consumption, but it would be possible to better check the costs, and at the end of the day, we would see savings, net savings of approximately 10% with this public universal system. So once you have a basic universal public system in place applicable to everybody, if a company then wants to provide additional benefits to the employees, it can do so. But at the very least, we would have a plan that is fair, universal, and efficient. So I'm going to move to this issue of the inefficient innovation policies. We're trying to attract the pharmaceuticals, but this kind of, this is $995 million in Canada for R&D, but it's $628 million in expenditures. So there's a serious problems. I think it's a time to stop artificially inflating costs. So in 30 seconds, just to take stock of the current situation, in terms of access, all is well in Quebec. Nonetheless, there are still problems with respect to fairness. There are a lot of problems, more specifically for those in precarious work, having to make do with a private system. In terms of the sustainability of the system, it is not sustainable in the long term. From today's perspective, we have a little bit of a system like Obamacare, and we're seeing similar results to the Americans. There is unfairness. We have tremendous costs in terms of the necessary reforms we should undertake. I believe that first and foremost, we should remove the issue of making private drug plans obligatory. If they're not compulsory, then we can expect that all of the bad risks will head towards the private system and only the good risks will remain in the public system. Obviously, that does present a challenge. So the notion of a universal public system is there to ensure that private insurance is not only there to manage patients who are profitable, whereas the other ones are left to the public. A public universal system in terms of financing is not so difficult. The premiums paid out in the private system will simply be paid in the public system. However, at the end of the day, we would have a discretionary income that is higher for the employee. I would be very at ease campaigning on that issue. And finally, we also have the possibility of buying drugs, and you add all of this, and it is possible for the Quebec model to become a model applicable to the rest of Canada. Thank you very much.